Go back. Okay, yeah, I'm going to swap this ways.
The mouse is on the other. You can minimize that. Yeah. Okay.
Oh, sorry. I probably can hide. Do you want to hide the meeting?
Yes, thanks. Yeah. Great. Okay. Hi, everyone. Thank you very much for having me this evening. It's been a pleasure to speak to you today, and a really interesting opportunity to chat about some of the work that we do in a different environment. As we said, I'm the program manager of the Suicide Prevention Research Unit. I need to update that slide. But I also just firstly want to acknowledge that I feel a little bit like Big Bird here, attending sort of a session where I'm definitely not an expert in AI or NLP or any of the very clever things you've been talking about today. And so I will be talking about sort of the work that we do and how we think that NLP might be able to help that work. But please don't expect any high-level technical knowledge or skills from me on that. But I'm very, very keen to learn from your ideas and feedback on the type of work that we do. So who am I? I am Big Bird at the moment, but the Suicide Prevention Research Unit at Orygen is a research department of the University of Melbourne under the Centre of Youth Mental Health. We're led by Professor Jo Robinson, and our team is sort of large and growing. And the work that we do is really focused on youth suicide prevention across a number of settings. So the work that we do is primarily in schools and education, clinical settings, so that's emergency departments, GP settings, and headspace and clinical sites, as well as social media, which is a big focus of the work that we do. And in fact, I've actually spent today out with a facilitating a workshop of young people looking at social media and self-harm and suicide communication. So if I'm stumbling over my words, it's just because I've been talking all day and I'm a little bit tired. So yeah, the variety of work that we do, but we try and work, all of our research really sits in all the places that young people live, work and play, and also, take this sort of multi-site approach to trying to support young people and the adults and the systems around them to support them. So just before I do start, I will just start with a bit of a content warning. So I'm going to be talking about self-harm and suicide today, which is a sensitive topic and can be upsetting for some people. Normally, we would be really careful about the language that we use around talking about suicide and self-harm. But for the purposes of this presentation, I actually do need to use some explicit language in regards to methods and means of suicide. So I'm just going to give you that forewarning, and if you do want to step away or take a break, that is fine. So suicide is unfortunately the leading cause of death for young Australians, and despite significant investments over the last couple of decades, the rates of suicide in young people continue to rise. So amongst young people, we see some concerning trends, particularly for different groups of young people. So more young males die by suicide than females. However, the rates of suicide in females is doubling at an alarming rate. So the increases in suicides by young females has more than doubled in a 10-year period, and continues to rise, and is currently impacting a lot of really young women and girls. We also see almost 4 times higher rates of suicide in young Indigenous people compared to their non-Indigenous peers. And we see other sort of marginalised groups of young people impacted significantly by this issue. And generally, it's not so much those identities that might be the thing that places somebody at risk, but it's the marginalisation, the discrimination that people might experience that increases their level of risk. When we look at data about self-harm, so we know that we know that self-harm is also a significant problem, and we have some reasonably good data around hospitalisations for self-harm. So we've seen sort of the trends for hospitalisation for self-harm sort of go up and down over the years. However, it's possibly more to do about how we're recording that data and the information coming from hospital systems. and again, we do see much higher rates of hospitalisation for self-harm for injuries by females compared to men, and consistently higher rates for young people compared to other age groups. Now, in terms of sort of quantifying the issue, we do see, we know that within the community, rates of self-harm are approximately sort of 8 to 10% in the general community, and that can include, and that also includes other suicidal behaviours. Yeah, sorry, stumbling over my words as I promised I would. So despite the work that we're doing, we are still seeing these increasing and concerning increases in young people. And deaths by suicide are really only the tip of the iceberg. So we have really good data from the Australian Bureau of Statistics around rates of suicide in Australia. We have really good, reasonably good data, which I've just shown you in regards to hospitalisation for self-harm self-harm or suicide attempts across the country. And we have a reasonably good idea about rates of self-harm and suicidal ideation in the general community. What we don't have is this missing piece here about emergency departments. So we don't have a reliable data source for how many people come into emergency departments with self-harm injuries or following a suicide attempt. We don't know what kind of care they receive, and we don't know where they go afterwards. So there's really this important missing piece. What we do know is that about 15% of people who die by suicide have presented to emergency departments in the last 12 months. So we know that, and about 50 to 60% have had some contact with other mental health or mental health services. So what we know is that points like emergency departments are a really important avenue for intervention, and providing people with the right type of care in that setting is really critical. But with these gaps in the data, and until we know what the problem is, we can't sort of start making recommendations about how to fix it. Thank you. Okay, so internationally, there's international clinical guidance and recommendations by the WHO, and as well as our own state and national suicide prevention strategies that recommend monitoring self-harm in hospital settings or emergency department settings. And internationally, there's a couple of systems that do that really well. So there's the Bristol Self-Harm Surveillance Register and the Oxford system in the UK. As well as an Irish National Registry, and here in Australia we have the Hunter Area Toxicology Service, which really mainly focuses on self-poisoning cases. But the Oxford Centre is really sort of the longest running centre, and has been consistently classifying data around self-harm to these hospital areas for many years. And the benefits of having a system like this in place is that we can use that data to inform policy and practice. So we can look at, when are people coming in? What kind of care are they receiving? Where are they going afterwards? Who's being referred? What's the follow-up from there? We can also look at the application of a guideline, evidence-based policies and guidance. So are nurses and doctors following the health standards for treating people with self-harm? We can also use it to evaluate the efficacy of different policy initiatives. So one of the current service systems that's being rolled out across Victoria is what we call the HOPE service. So HOPE, and it stands for Hospital. It's going to leave my brain, but it's an aftercare service basically. So it's a service that is linked up with a person within sort of 72 hours of their presentation to ED, and it then they then receive a targeted 3-month follow-up episode of care, which really sort of maintains that safety around them for that really critical period. We can also, from sort of from a research and data and national interest level, again, fill that gap that we've got in terms of data. So we can get really good reliability around the epidemiology of self-harm, and we can also look at rates of repetition. So are people coming in to the emergency department more than once? How often? And what keeps them coming back? So the way that our system is set up, we do want people coming to EDs if they are in crisis and if they need if they need support. And the way that our system currently works is that emergency departments are the best option for immediate care for self-harm or a suicide attempt. However, we don't want them to keep coming back. So what we want is for them to be receiving good quality care, to be receiving good referrals and follow-up care and support and safety back in community or with specialist services. We don't want them to be using the ED as the only point of care. So for all these reasons, putting together a self-harm monitoring system based in emergency departments is a priority. So I'll introduce you to our emergency department study, and it includes a number of different features. So we first aim to set out and develop a self-harm monitoring system, and from that develop a lead indicator for suicide-based presentations in the ED. We wanted to look at those gaps in data collection and recording and look at those issues around patient management and care and try to get a better understanding of what's going on there. We also wanted to understand what are some of the barriers to providing optimal care, both from the perspective of care providers and from care receivers. So people who we did a qualitative study a couple of years ago, talking to young people about their experiences of presenting to the emergency department, what that felt like, how they felt, what type of care they received and what that experience was like. And we've done the same with staff and some quantitative work as well. We then want to use this data to do things like evaluate our aftercare service. So Orygen, following the Mental Health Royal Commission, has received funding to establish one of the first youth aftercare services. So we want to be able to use our emergency department data to tell us whether the aftercare service is reducing rates of representation or rates of presentation to the ED. And we want to improve outcomes. So we want to make sure that this data is informing care, improving the way that we treat people, and also being useful for hospital sites as well as people receiving the care. I'm just going to focus on the data elements of the work here, but in terms of the development of the self-harm monitoring system. We, a couple of years ago, received some funding from the Department of Health, and we put that on top of a bit of funding that we already had from some philanthropic funding to establish and expand the work. So the Department of Health funding, so we started the work in Western Health, so that's Sunshine, Footscray and Williamstown emergency departments. And we then expanded the work to the Royal Melbourne Hospital, and then the Department of Health funded us to expand to 2 regional sites, so Latrobe and Ballarat, and 2 more metro sites, so the Alfred and Frankston or Peninsula. So, if the system's up and running well, then we should be able to cover this, fairly, sparse region of Victoria and capture a good percentage of hospital presentations in that across the state. So the data that we collect from emergency departments, it is triage data. So it's data from the triage system. And these are the different variables that we receive and that we've got, ethical approval to receive. And in terms of sort of working out which data we need, we had to work closely with sites and sort of work out, how do you when somebody arrives into the ED, what are the questions you ask? What kind of variables have we got? What would that be useful for? All of that. And I've got a couple highlighted there. So one of them is the diagnosis code, which is the ICD-10 code, and the International Classification of Disease Codes is this, very vast, coding and classification system, which gives sort of a code for any kind of medical illness. There are ICD codes related to mental health and also to mental health presentations and also to self-harm. However, they're not systematically used. So when we first collected this data, we thought, oh, we'll just check the ICD-10 code. And then we realised that actually there was very, very few people in those presentations that were coded for self-harm. And we talked to our hospital site and they said, well, yeah, but if I had a person come in with depression who's just self-harmed, I would probably code that as a general mental health presentation or primarily depression, and I wouldn't code the self-harm piece itself. The other tricky part is that the Victorian emergency minimum data set asks for these other variables, these red ones here. So if you any injury so whether that's a self-inflicted injury or an injury from any other cause, they ask for all these fields to be filled out. And again, speaking to our hospital department friends, they said, well, you know, it's a busy shift, and you know, I'm going to either code it as a general mental health piece, or if I have to fill in the, you know, the injury measures, I generally won't do that for a self-inflicted injury, or I won't go to sort of all of the so there's sort of 4 fields that you've got to fill in before you get to human intent, that the injury was of human intent, and then you've got to, you know, so, you know, 4, 7, 8 additional fields that was just, you know, that they were just not using it primarily. So we're like, okay, well, we've got all this data and it's telling us a lot, but there's a lot of data. And so when I say we're collecting this data, we're not just collecting this for self-harm presentations. We're collecting this for every presentation to every hospital for a period of 2012 up until the end of next year. So we've got sort of 6, 7, 8 years of data of every presentation to 8 hospitals across Victoria, and we've got to sort of work out which ones of these are self-harm related. So we then, again, in working with our hospital colleagues, we had a chat and they sort of said, well, look, the most information you're going to get is from the triage comments. So that's the free text field where the, you know, triaging nurse will give a brief summary of what the presentation's about. So we looked at them, and yes, they are quite informative. And so we went, okay, well, we'll code those. We'll go in and we'll code those and make sense of that. And then, you know, we'll be able to tell which one is which ones are self-harm. I actually need to just skip ahead because I want to show you what one of these triage notes look like, and this is where the language and description of the injury might be a bit confronting, but some of the triage notes might look like this. So self-inflicted cut to the left forearm, dressed by GP, nil further bleeding, previous history of self-harm, depression, extensive mental health services as per patient, blah, 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 right? So information in there, some of it relevant, some of it not, lots of spelling errors, lots of sort of, you know, back and forth. And, you know, you might sort of say, okay, well, we've got right there, we've got a current injury, and we've also got a previous history. So that's, you know, relevant information. You then might have something like this, emotional crisis, recent breakup, had OD 24 times Nurofen, previous history of BPD, vomited twice, and back pain. So what we need to know there, is that a self-inflicted injury? Is that a self-harm episode? Has somebody intentionally, you know, taken that many Nurofen? Do we know how many Nurofen is safe to take in a period? So all these sorts of things we need to know, you know, from a clinical perspective to know, okay, that's a dangerous amount of Nurofen. So yes, we would classify that as a self-harm episode. And then you see like pieces like this, which might be, you know, suicidal thoughts and self-harm, wants to see emergency mental health and wants help, previous history of depression and anxiety. So the word self-harm is there. We've got suicidal thoughts, but in terms of the way that we want to classify self-harm, which is the, you know, intentional injury regardless of, self-injury regardless of intent. So whether that's suicidal intent or not. We're not quite sure here whether self-harm's actually happened or whether there's just thoughts of it. So this is the messy data that we're dealing with in thousands and thousands and thousands of cases. So we had an idea, you know, when we started this work and we started getting into started, well, there must be an easier way to code this. There must be, you know, well, maybe we take the ICD code and we put it plus this, or we do this or whatever. And we came to sort of realize there must be just certain language that we would use in our triage notes that would tell us one way or another that this is definitely self-harm or this is not. And so we had this great idea. We're like, what are the words that would normally be used? And we made a list and we thought about another list, and then with, you know, all of that. And, you know, we're not, you know, technical experts at all, but we sort of started to apply this, like, you know, this manual coding rule. And, you know, it worked in theory, but again, we've still got tens of thousands of cases sitting in front of us. And we've got 2.5 poor RAs who are doing this coding, you know, day after day, looking at these codes. So we partnered up with some colleagues of ours, I think, well, I'm not sure actually where they are anymore, but I think they've moved around. But you probably know them, Karen Vespor and Vlada Rasova, who were working on sort of natural language processing models. And we talked to them about the data that we've got and the idea that we had, and wanted to, to work together and sort of solve this issue. So we developed the protocol of how we wished it would happen, or how we wanted it to happen, and then went about testing that. So this is sort of how, we take the data into the system, we de-identify and classify, it goes into the database, and then there's this case ascertainment procedure through the NLP magic, which I'm not going to try and explain to you. It goes back into the database, and then we've got we can then look at just the self-harm measures, and then we can look at, more specifically, this is what the injury is, or this is specifically what the care was. Just go back and forth here. I haven't really set this up well. So they wrote this great paper for us, which described the process, and I'm not going to try, I can't do it justice in trying to sort of explain it. But this process might make more sense to you. But they used a test, what are we calling it here? A holdout set, I think. And you're going to correct me if I'm explaining this wrong. But they used a set of our manually coded data of 6 or 8 years. And they use that to train the NLP to say, this is what is the self-harm case and this is what's not. And then, we worked to refine it, and we kept coming back to these questions. They're like, we've got what do we need to know? What kind of cases does it keep tripping over? So then we looked at, the language in, we took sort of a clinical look at the language that was in the triage notes and sort of helped them. We said, oh, well, that means this, or that means previous history of, whatever. We had to sort of build into it this medication log that sort of says this is too much Nurofen and this is an okay amount. And so we had to have all this sort of background sort of MIMS knowledge and, taught all that sort of thing. And they then, used our manually coded data in the Royal Melbourne Hospital site to train the NLP, and we started getting some really good results. Here's some examples of some of the cases that might be sort of false positives. Yes. No, sorry, this is false negatives. I've mislabeled this. So false negatives. So again, a case like this, a patient brought in by mental health team for suspected overdose of meds, multiple blisters missing from Webster Pack, low mood at triage cooperative. So that has been coded as a control, but actually there is evidence of self-harm for the amount of medication taken there. Again, sort of particularly issues around the quantity of medication seem to be one of those things that sort of kept tripping it up. And then these are the actual false positives. And it's actually not that very big. But again, we sort of see cases where there might be a reference to a history of self-harm or a history of suicidal thoughts, and those types of things kept coming up as false positives. So they worked their magic, they retrained it, and we got this, a really good fit for the Royal Melbourne data set. Now, so that's great. And so we then thought, okay, that's one hospital sorted. We'll just add in all the other hospitals. And guess what? That didn't work. Because each hospital has their own sort of idiosyncrasies about how they code their data. They use different fields. So in some hospitals, they call it a triage comment field. In other times, it's a presentation description field. And so we had to, within our database, we had to be asking for different variables. We had to, sort of reconfigure the way our database was reading things. So we then tested it going into one of the other sites, and that was the other site that we had the most coded data for. So again, a really large amount of manually coded data was used to train the next hospital site based off the original results of Royal Melbourne, and it broke. And I can't go into the technical detail of why it broke, but it was working. Royal Melbourne wasn't going to be the Royal Melbourne model wasn't going to be a good predictor for understanding the La Trobe data, for example. And so we knew that then that's going to, if we have that issue with one hospital, then we're likely to have it with, with subsequent other hospitals as we keep adding to the network. So, okay, fine. We'll just sort of keep working on it and just, sort of see how we go. However, I want to show you a timeline of this project and how long it's taken us to get it to this point, and some of the sort of ethical and funding issues that have sort of come up with that. So we started this work as a pilot at Western Health in 2016. In 2018, we got ethics approval to expand to the Royal Melbourne, and that's when we received the funding from the department to expand to those additional 4 sites. In 2020, we had to revise all of our Royal Melbourne ethics and governance to make it a multi-site study. It was quite an arduous sort of process. We started building this new database. We published the protocol and said, here's our great idea, here's what we're going to do, off we go. And those green dots are obviously COVID. And so then all research in emergency departments that were not COVID related got shut down. So we couldn't access any data for that time. We couldn't onboard new sites. We couldn't step foot into an emergency department throughout COVID. So in 2020, our department funding expired. They gave us an extra year, unfunded, how generous. But we still couldn't do anything in that year anyway. So the funding ended, and then we're still chasing ethics approvals. And we were propping the project up with funds from other projects and trying to kind of limp to the end and all that sort of thing. We get to 2020, we finally get approval at Frankston. Just this year, we got approval to go into the Alfred, and with each site, we have to have these, it's a lot of sort of resource to get set up in the site. So we've got to get to know their site, their data. Their data's got to talk to our database. They've got to learn the systems. We've got to have all the right data sharing agreements in place. So just getting any site off the ground is a long and arduous process. This year, we finally got our database finished. But we're out of money. We're out of money. We're out of resource. We can't sort of keep going, and we are really stuck as to where do we go from here. So and as of the end of next year, our current ethics approval ends. So what we can't do is go back to the department and say, hey, give some more money. And what we can't do is go back to ethics and say, let us keep doing this for another 5 years and just see how we go. So, all of these, things is just been a bit of a perfect storm. So I've just spoken about, some of the challenges that we faced. We've also probably had a bit of a mix of personnel. So we've had some team members leave and new people start, and sort of had just some of that inconsistency in terms of the management and the running and the day-to-day work of the project. There's this, major burden of manual coding. So firstly, it just takes a lot of time, a lot of resource to be coding 10,000 cases from each hospital per year. But also, it's not a very fun job. Our RAs don't want to be sitting there looking at injury logs and cardiac episodes and all of this stuff all day. It's not a good use of human time. And we've also, built up all these great relationships with the different hospitals, and then, your champion on the site will move on somewhere else, and then you've got to start all over again, and you've got to get that site to, trust you with their data and trust you with their ethics and all that sort of thing. And also, we don't have the NLP expertise on our team, so we have this great collaboration, but also this is not their priority. They were kind of doing it as a favour for us, and we weren't funding them, so we can't sort of say, keep working on this part of the project. Just because you think it's really interesting, we'd love that, but we want to be able to properly resource that expertise or bring that expertise in-house. So that's where we're stuck. But what I'll talk about is just some of the data that that we have been able to publish, and I guess some of the things that we can learn from that. So this is a snapshot from the Royal Melbourne Hospital. For presentations between 2012 and 19. So we looked at this period specifically because we didn't want to touch the COVID period just yet. So we sort of specifically looked up until 2019. So I'm really not done great with the colours of this slide. But these is rates of presentation by age. So the dotted line is people over the age of 25, and the bottom line is, no, I'm sorry, I can't even say that. But we can sort of track the rates of presentation over time. And what we can see is that presentations for self-harm have increased over that period of time. We can also look at the characteristics of those presentations, so we can look at the different methods that are coming in and what are some of the most prevalent methods. In most cases, I think about 70% are self-poisoning, so that's ingestion of pharmaceutical or chemical or prescribed or non-prescribed drugs. We can look at the involvement of alcohol or other drugs in self-harm, which we know is a common comorbidity and common risk factor. We can also look at the how many people received a mental health assessment while they were there. So so everyone was seen by a medical doctor, but only about half of people were seen by a mental health worker. And then we can also look at discharge destination. And you'll see in this, so this is where people go as they leave the ED. And you'll see that there's sort of some changes in the trend here where it used to be common that most people would just be discharged home. And then in about sort of 2015, 16, they opened a short stay unit attached to the hospital, which had a particular special expertise for mental health. And so they then, started moving people in there for a little bit more care and observation. So we weren't just sending people home. So these are the kind of things that we can say, well, actually, that seems like a good initiative. That seems like something that, we should be investing in other hospitals. So between 2012 and 19, there were, 500,000 presentations to the Royal Melbourne ED, just a bit over half of them females, and 7,736 were self-harm related. So only 1.4% of those millions of cases, thousands of cases that our coders are coding are actually the gold that we're looking for. But we could say that there was also this repetition event rate of 11%. So 11% of people are returning to EDs. We can see that self-harm presentations increased 5% by about 5% each year and 44% over that 8-year period, and that the rates of presentation for young people were more significant over that time. So we can also look at the most common method was self-poisoning, as I mentioned before, and people were not often seen by mental health staff, and we also know how soon people are coming back to ED. So thinking about models like that aftercare model that I spoke about, if we give people that right amount of care in that first 3 months, will we see them again at 4.5 months? I'm not sure. So the potential of sort of using this data, once we've got a good handle over it, to sort of inform some decisions. So one of the big changes that came about as a result of the Oxford system was, again, they saw a similar thing, that one of the most commonly used methods was overdose, and most commonly by paracetamol and other sort of over-the-counter pain relief. So they implemented a policy using the data from their system, implemented a policy where you cannot buy more than 12 paracetamol at a time. Whereas here in Australia, you can go into any chemist warehouse, you can buy 6 boxes of 200 Panamax, and nobody's going to ask a question. So using this data to inform how we target means restriction, how we target policy, how we fund and inform care is really important. But as I said, we're stuck. Like, we're not sure exactly where to go from here. So I'm just about to finish up, but I guess the couple of things that we are sort of finishing up in the meantime is we've got a couple of papers in the work. So we'll be sort of publishing the characteristics paper for the La Trobe Regional Hospital. We'll be looking at sort of the data from the COVID period in both metro and regional sites. But again, years and years worth of manual data coding means that we're not really providing any evidence in a useful real-time frame of time. So COVID data might have been interesting in 21 or 22, but we're sort of 3-4 years out of COVID now. So there's already been other data published that's shown us that there were increases in presentations to self-harm. So what are we actually adding to this if it's taking us so long to turn around and transform this data? We will be using the data to, as I mentioned before, evaluate the Orygen Youth Aftercare service. So that service has been sort of in operation for just over a year now, and we're doing a really large evaluation of that over 5 years. although we've only got ethics for this piece of the data for one more year, but I'll come back to that. We're also using it in some dynamic systems modelling from a colleague of ours who's over from the University of Birmingham to inform, specific regional DSMs for mental health care for young people and suicide prevention, particularly in the northwest of Melbourne. And we're also going for funding bids and trying to sort of make a case, but again, the resourcing that needs to come into it is a really big question. I think ethically, it would be. I think personally, I think it would be a big shame to let this project die, or to lose this really valuable work. I think ethically, it's irresponsible for us to have this huge amount of very sensitive hospital data just sitting on our database and not doing anything with it. I think that's I don't think that's right. So. Yeah, that's where we're flat. I don't have any answers. I can't wrap it up into a nice bow for you, but I'm really keen to hear people's thoughts and questions and ideas, and yeah, that's where NLP has got us.
Yeah. Thank you. This was very interesting and important topic. So you mentioned that the model that was trained on one hospital data, it wasn't really useful for another hospital, which I can understand. My question is, so you mentioned that you have data from 2012 to 2023, and we had 2 years of COVID there, and then the consequences of those COVID years after that. How much do you think that has skewed the data in a way? I mean, COVID years has skewed the data in a way that the data prior COVID years are not useful.
So I actually don't think it has, because I think that the data set that we trained the model on was only up until 2019. So we again deliberately avoided the COVID years. So I don't think it has skewed it. But the other thing that I'll say as well is that across that time period, a lot has changed in practice and technology in EDs. So a lot of our sites, in the middle of that period, they've changed data systems, they've improved their data coding, they've improved their staff training around these things. And so, we see at some points these really big jumps or changes in the data, and we're like, oh wow, suddenly there's a massive increase in self-harm presentations. And then when we talk to the site, they say, no, we just we changed the classification. We made it mandatory that they have to hit that, they have to fill out that field around, human intent, or we made it mandatory, we did some training and, it increased sort of, awareness or things like that. So, or we introduced a short stay unit where it just changed the way that we, treated those patients. So, so I don't think that COVID's had that much of an impact, but I do think, such a large period of time, there's all these other changes that have happened in the service system in that period that are kind of throwing up funky things in the data anyway.
Very interesting presentation. I have one question and one suggestion. First of all, is what would you take, like if you had to start this today, what you will do different? So you are not going to be sort of. And my second question is related to what to do with this gold mine data set that you have in your hands, because I really think that having 500,000 annotated data set is very, very rare in the whole clinical NLP world. So I was wondering if there is the opportunity to sanitize this data, anonymize it, and make it an open source data set, because that could really help you do something with this.
Yeah, two very good questions. What would I do differently? Everything. No, I think I think better partnerships with hospital sites, or the work being led by the hospital is probably one of the biggest learnings. I think, us coming in as researchers and sort of saying, we just have your data and then we'll tell you, how poorly you're treating these patients or whatever, that they don't tend to, react well to that. So I do think sort of having, and the sites that we've done the best in is when we've had a really good sort of clinical champion there. So I think the work being sort of, led or initiated or, co-led, excuse me, co-led by the hospital sites themselves is very helpful. We did think that it would help us sort of having the Department of Health on board and sort of going to these sites and being like, Department of Health says that you have to give us your data. That didn't convince them, or, they still sort of had, questions and queries and things like that. But having that investment from the department in terms of scaling up the system or going anything further would be integral. And in terms of setting up a system like this, I would just say, think about how long you think it's going to take you, and then double it, and then probably double it again, double your resourcing, double your funding. We've got a lot of learnings from this, and I think there's also probably, hopefully, being able to share and translate some of these learnings into other systems in the future would be helpful. And the other question was about the open source question. I don't think our ethics would allow for that. I absolutely see the value in it. But I think when we sort of talk about the advancements of how far along these technologies and systems are, as much as we all really respect and value open source and open science, I don't think our human ethics committees are there yet, unfortunately, nor are some of our health systems, and particularly in terms of sort of personal, even de-identified data.
Thanks for sharing. It's like a really fascinating one. I'm just a little curious about, for example, for certain EPs, for example, like eating disorder, it usually takes, for example, like several therapy sessions, so the patient, they can actually starting to expose themselves. So it can be extremely hard to actually gain their, for example, like text informations, actually conducting certain experiment on them and to collect a huge enough data to do some NLP experiments. So I wonder how to actually you guys design this kind of experiment. This is the first one. And the other one is due to the sensitiveness of this information, how to actually collect these kind of enough data. So they take like a super long time. So in that case, for example, a single project may take one or maybe several months to collect all the information. So how to deal with this time cycle problem?
Yeah, I'll answer the second question, then I'll come back to the first. In terms of the how long it takes to collect this data. So these kind of systems really do need to be set up to run longitudinally. And we so when we started the study in 2016, we sought ethical approval to get data from 2012. So it was then a retrospective collection of already collected data. And one of the benefits of the way that we collected this data was that we said to hospitals, you don't have to do anything. You just need to give us access to the data that's already in your system. So that was sort of an easy win. They didn't, triage staff didn't have to learn a new coding system or anything like that. And then it became a prospective data collection. So every 3 months, we send each site an email and say, can you please upload your data from the last quarter into our database? So that's how we get those big numbers. And ideally, if we were able to code this data and turn it around quickly, we could almost be sort of real-time reporting. And when I say real-time reporting, we're not going to be getting, the daily numbers like Dan did during COVID. But what we can say is, over the first 6 months of this year, this is what we saw in hospitals across the state. And I think that would be, useful to be monitoring some of those real-time things. So when there's a trend of a new method emerging, for example, you could put in place sort of strategies to restrict that means, or you could also look at the effect of certain social or sort of media things. So we can look at, if we had this data in, ready to turn around really quickly, we could have been saying during COVID, well, this is what's actually happening real time in our EDs, and this is the impact that significant lockdowns are having on the young people of the people of Melbourne. We could also use it to to look at things like people might be familiar with the TV series 13 Reasons Why, which was on Netflix a couple of years ago. And it, tells the story of a young person who takes their life by suicide, but the depiction of the suicide was really graphic and unsafe and caused a lot of distress for people. And so we can sort of look at, well, hang on, how many young people are imitating or engaging in that behaviour following seeing something so distressing like that. So we can, if we had that, real time or quicker time, we'd be able to answer that question. In terms of the eating disorder question, I didn't quite understand the context of that one. Oh, yes. Yeah. So in terms of the patient exposure, so the type of ethical approval we sought was the same that you would get for like a quality assurance project. So we sought a waiver of consent to say that this is already routinely collected data, and the consent for access to the data was coming from the hospital, not from the individual patients themselves. And we obviously received it de-identified. So so that's how we overcame that question.
Okay, we're running out of time, unfortunately, but let's thank both speakers again. Juice is stick around for a few minutes, and thanks to all of you for several Zooms.
No, I just can't stop that.
Don't have it. There was someone. Are you still in the Zoom?
Yes, I'm still.
Message that they wanted to get in touch with you. Open the chat. I don't think there were questions, but someone wanted to.
Yeah, that was me. Let's get in touch. Okay.
Study.
Yes. Study.
Take a picture.
Oh yes, I'll grab my. Oh yeah, thanks.
Thank you.